To become a practicing physician, a person must dedicate a decade or more of their life to grueling, highly competitive training. Yet right now, the industry is witnessing an accelerating mass exodus of the very talent it spent so much time and money producing. Physician attrition rose from 3.5% in 2013 to 4.9% in 2019. Today, overall burnout hovers near 42%, leaving half the workforce symptomatic. Moreover, 32.6% of academic physicians intend to leave clinical medicine within 2 years. Career satisfaction has dropped so much that over 40% of current physicians state they would not choose to enter the medical field again. Listen to practitioners describe their day-to-day reality, and you hear highly accomplished surgeons and primary care doctors admitting they feel like failures, describing their required workload as straight psychotic. The healthcare system is actively hemorrhaging its most valuable, highly trained assets exactly when they should be reaching the peak of their operational usefulness. The healthcare industry's traditional response to this crisis treats burnout as an individual psychological deficit. Administrators deploy wellness modules, mindfulness apps, and mandatory resilience training. Clinically and operationally, these symptoms signal a state of moral injury, a specific outcome of structural administrative failure. Moral injury occurs in a clinical setting when a physician's institutional mandates violently conflict with their altruistic, evidence-based training. It is the psychological trauma of knowing exactly what a patient needs and being blocked by the system from providing it. To understand how we reached this breaking point, we must map the chronological life cycle of a modern physician and isolate the systemic variables driving distress. Reframing this excess as an administrative disorder allows us to stop questioning the practitioner's mental toughness and start examining the structural design of the healthcare system itself. This timeline tracks the emotional and systemic journey of a physician's career. It starts here, in Phase 1, medical school and training. This phase establishes an altruistic baseline. Trainees endure immense personal and financial sacrifices under the strict belief that their endpoint is providing high societal value and community care. But moving into Phase 2, early clinical practice, that idealism collides with the reality of modern medical infrastructure, specifically the burden of the electronic health record, or EHR. This collision creates what is known as the shadow shift, an invisible, uncompensated administrative workload that permanently disrupts a doctor's cognitive focus. The mathematical reality of this shift is staggering. The average physician must now spend 1.5 to 2 hours on documentation for every single hour of direct patient care. Over the course of a typical month, 57% of clinicians lose more than 44 hours to documentation alone. That is an entire standard workweek dedicated entirely to screen time. Add to that an average of 77 uncompensated, unscheduled inbox messages arriving every day, and personal boundaries of physicians' role, converting high-level patient care into an endless, algorithmic data entry task. As administrative friction hardens into an active loss of control, the physician enters Phase 3, systemic consolidation. Back in the 1980s, nearly 20% of doctors operated in personalized, independent practices. Today, that model has been rapidly replaced by centralized, corporate-owned healthcare conglomerates. 83% of surveyed physicians point to third-party practice acquisition and market consolidation as the primary drivers of their autonomy loss. This is exactly where moral injury crystallizes. Insurance companies run by non-clinicians actively dictate which medications, surgical implants, and physical therapies a doctor is allowed to prescribe. This constant overriding of clinical judgment damages the workforce. 73% of physicians report elevated stress specifically due to these rigid limits on their independence. Stripping away clinical autonomy transforms a highly trained scientific expert into a protocol-following technician. The resulting environment breeds profound professional betrayal. This root cause matrix maps administrative failures to their consequences. Row 1, EHR demands cause exhaustion and rushed appointments. Row 2, autonomy loss forces standardized care. Row 3, corporate interference creates moral distress. Row 4, inadequate staffing catalyzes severe medical errors. Every major stressor pushing doctors out of modern medicine originates from systemic bloat and administrative constraints, not from the complexity of the patients themselves. This brings us to the final stage of the physician's clinical life cycle, Phase 4, moral injury and resignation. Providers describe a crushing guilt and sadness at this stage, caused by the sheer inability to truly follow a patient's story through their illness. Systemic pressure requires organizations to prioritize patient throughput volume over treatment quality, forcing an unacceptable ethical compromise on the provider. The modern doctor is ultimately faced with a stark decision. Many realize that leaving the profession entirely is the only reliable way to preserve their personal sanity and moral baseline. The system actively corners practitioners until abandoning a lifelong calling becomes the only morally sound choice remaining. When a doctor leaves, the impact radiates outward, causing a rapid, invisible decay across the broader healthcare network. This chart shows the economic fallout of mass resignation. Replacing a single physician costs a hospital between $500,000 and over $1 million in recruitment, onboarding, and lost clinical revenue. Geographically, as doctors walk away, access evaporates. This creates critical shortages that hit rural areas and underserved populations the hardest. Physicians managing highly complex dual eligibility Medicare and Medicaid patients face a 57% increased risk of attrition, meaning the system is failing its most vulnerable demographics. This fuels a vicious cycle. Fewer doctors means the remaining staff must absorb higher patient loads, compounding the operational stress that caused the departures in the first place. This moral injury translates directly to patient outcomes. Burned-out doctors show statistically higher rates of medical errors, and a noticeable reduction in clinical empathy during appointments. It also creates a severe perception gap. While 91% of clinicians believe they deliver quality care, only 67% believe their patients actually feel highly satisfied. Treating physicians as expendable, high-throughput corporate assets creates a healthcare infrastructure that is fragile, dangerous, and exorbitantly expensive to maintain. Historically, the immense stress of practicing medicine was balanced by the rewards of clinical autonomy. Today, that branch has been destroyed. Attempting to combat this crisis by deploying wellness modules and resilience training is an inadequate, even insulting response to a deeply structural problem. The required interventions are structural. The healthcare system must restore clinical autonomy, systematically strip away administrative EHR bloat, and permanently remove non-clinician interference from the exam room. Until medicine cures its own administrative disorder and returns the physician to the center of patient care, the moral injury and mass exodus of its greatest healers will only accelerate.